Yes, absolutely. Thank you very much for this opportunity to talk about something that I think is really important as we, try to solve the maternal health crises in the U.S., also in our state. Um, I am deeply passionate about this area. I see a lot of pregnant women with heart disease, high risk pregnant women with heart disease. But as a preventive cardiologist, my focus has always been on understanding cardiovascular risks that have been accrued during pregnancy or the postpartum timeframe, and how to optimize postpartum health for our individuals with adverse pregnancy outcomes. Much of my research is on the intersection of adverse pregnancy outcomes such as preeclampsia, gestational diabetes, preterm birth, gestational hypertension, and their future cardiovascular risks. And so I hope to present my top 5 updates in that field with the sense of focusing on optimization of cardiovascular health in our pregnant patients, which is a very big unmet need. So is my slide, okay, did it advance? Okay, so these are my disclosures. They're not pertinent to this talk, but I'm supported by the American Heart Association to understand the impact of social determinants of health and hypertension in women. My top 5 takeaways today will be focusing on interventions that cardiology can support OB and MFM with in the interpregnancy and the postpartum timeframe. Number 1, we have recognized that adverse pregnancy outcomes have long-term impact on cardiovascular health. The figure on the right here that says Table 2 is from the American Heart Association scientific statement on adverse pregnancy outcomes and heart health. What we know is that individuals who have had these adverse pregnancy outcomes are at an increased risk of premature cardiovascular disease, whether it's premature coronary disease or heart failure or cerebrovascular disease. And there is really good evidence supported by multiple large meta-analyses and large population-based studies done both in the US as well as outside of the US that really focuses on this risk. We also know that adverse pregnancy outcomes are shared disorders with a placental etiology, likely hypoxia or inflammation of the placenta. But it is not unusual to find patients with adverse pregnancy outcomes that also have underlying cardiovascular risks, such as obesity, hypertension, metabolic syndrome, and a poor economic status. And so I think thinking about APOs and reduction of APOs should also focus on reduction of cardiovascular risk before the APO develops, which is improvement of cardiovascular health in the interpregnancy and antenatal timeframe. This is a large meta-analysis of 22 studies and had over 250,000 women with preeclampsia that were followed from 6 weeks onward to about 39 years of follow-up. And what they found in this was that is the box in the red, which I want to highlight, that the association of preeclampsia with coronary disease, with heart failure and stroke was about 4-fold high, in that early postpartum time frame, which is 1 to 10 years or early APO time frame. And then that risk gets attenuated over time because maybe women or individuals develop their own individual risk factors, but the earliest risk is in the first 10 years. And so it's important to think about what can we do for our pregnant patients or patients desiring subsequent pregnancy to improve this risk so that this long-term lifetime risk is reduced, but also there is an achievement of wellness. The problem is that a lot of our women don't actually see preventive cardiologists or primary care doctors in that time frame. And so the risks that can be improved and can be intervened on generally are missed opportunities. Preeclampsia and subclinical cardiovascular disease. In the cardiac literature, there has been so much now associating preeclampsia with early disease. This is a paper that came out from the Swedish group that looked at patients with preeclampsia and at what age did they develop coronary calcification, which is blockages in their heart arteries that we see on a coronary CTA or CT of the chest. And what they found here is that in asymptomatic women who had previous preeclampsia, they increased their risk of coronary calcification and subclinical calcification faster than the women who did not, which is the panel below that says no previous preeclampsia. And the highest risk was seen in women of 45 to 50 years of age. Again, a point of intervention for us, because typically we're not checking subclinical atherosclerosis in these patients. But association is not causation. What we don't know is that whether the APO increased the risk itself or it's merely uncovered during an APO. We also don't know if cardiovascular disease abnormalities can be recognized early, really early after an APO, and what we can do to identify those risks and to mitigate those risks. Number 3, critical time windows. The Heart Association focuses on critical time windows to advance cardiovascular health. We define cardiovascular health in all individuals based on 8 factors: your diet, your exercise level and activity level, your blood glucose level, your weight, your blood cholesterol, your blood pressure, smoking or anti-smoking, and sleep, which we define as life's essential 8. People in the green zone are people that have really good metrics in all of these. Their weight is under control, their blood pressure is normal, their lipids are normal, their glucose is normal, they're getting enough exercise. But we know that about 60% of the women entering pregnancy have suboptimal cardiovascular health, which means 2 or more of these risk factors have already occurred in these patients. So improving cardiovascular health of pregnant patients is a very important step in improving their overall lifestyle. We also think that pregnancy is a window of opportunity where patients generally are attuned and are seeing healthcare professionals. So designing care of patients where we can focus on cardiovascular health, not just postpartum, but also during pregnancy is important. And we really have to focus on developing algorithms and care pathways that help focus on premature coronary disease. I put this out here because this is another statement from the American Heart Association focusing on a warm handoff of patients with APOs and warm handoff to primary care or to cardiology, where after 6 weeks visit with the OB, there are certain risk factors that are looked at that are followed up at 12 weeks, followed up at 6 months, and followed up at 12 months at these given intervals, so that their health is optimized in this time frame. Number 4, what can we do to address cardiovascular health? I think multiple interventions are needed to reduce and aggravate of these risk factors. Controlling just one risk factor is not enough if you've had more than one. Management of stress and anxiety and postpartum depression and screening for postpartum depression is helpful because mental health impacts cardiovascular health. Psychological health makes a very big difference in the lives of these patients. Psychological well-being, mindfulness, optimism, gratitude, sense of purpose. We don't really have a good randomized controlled trial to say that this actually works. But why wouldn't it work? It's something that is intuitive. If your health is good when you enter pregnancy, you're less likely to have an adverse outcome. So we really have to sort of focus on what best data and best practices are in hypertension management and diabetes management and obesity management. We know that a recent CHAP trial that came out of the OB literature looked at better optimization of chronic hypertension in pregnant patients with a lower target of less than 140/90, actually improved outcomes, reduced preeclampsia, reduced the composite of preterm birth preeclampsia, and did not cause an increase in small gestational age infants. So focusing on really optimizing chronic hypertension and controlling chronic hypertension is a really low-hanging fruit. These are, again, postpartum considerations, checking hyperlipidemia, hypertension, diabetes, tobacco, physical activity. But despite all our efforts, our awareness remains really low. This data is from the American Heart Association's Research Goes Red registry that is looking at reproductive experiences across the US. This is a well-paying population that has access to care and has access to internet so that they can go in and register for their Research Goes Red registry and take this questionnaire. These patients are attuned into their health. And they were asked, what were your experiences in your subsequent pregnancy, in your current pregnancy? 30% reported that their providers did not assess pregnancy history in their current pregnancy. And about 59% of patients were not educated regarding associations of APOs and long-term risk. And 63% actually were unaware that cardiovascular disease is actually the leading cause of maternal mortality. Number 5, I put this here because severe maternal morbidity is going to be increased. Severe maternal morbidity is really a problem. Much of the maternal morbidity is contributed by cardiovascular disease, existing cardiovascular disease. And so predicting maternal morbidity or predicting in which patients maternal morbidity is likely to occur is important. Lack of access to healthcare and lack of optimization of healthcare can lead to increase in severe maternal morbidity, as seen in this study, where maternal morbidity doubled in the expected management of pre-viable pregnancies in the state of Texas. The ACOG recommends that pre-viable pregnancies with premature rupture of membranes can either be managed expectantly or can be terminated. But in states where that's not available, these patients may be at an additional risk of other factors that complicate their birth. So with that, pregnancies complicated by adverse pregnancy outcomes are associated with an increased cardiovascular disease. We need better strategies to manage and optimize health in the postpartum timeframe. Ideally, these should begin prior to pregnancy, should be maintained during pregnancy and continued in the postpartum timeframe. And we really need further research to understand the pathological risks of preeclampsia and premature coronary disease, and what is the relationship. We just don't have that data yet. With that, I will stop sharing.
Excellent. Thank you very much, Dr. Sharma. Does anybody have any questions? I know that was a lot of information in a little bit of time, but I think it was a lot of valuable information. So thank you for presenting. And I, yes, agree, second all of this. This is a very important topic, and we are seeing this a lot more. The prevalence is a lot higher with what we are seeing both in Virginia and nationally as it relates to cardiac conditions and pregnancy. So a very timely topic. So does anybody have any questions? If you want to either put them in the chat, or the question and answer option is open as well. Maybe you just covered everything so flawlessly that we'll give it.
I will take that as a positive.
Yes, absolutely. We will give everybody a few seconds. I know sometimes typing is a little bit slower than just coming off mute. Oh, there's a question. Yeah, so Dr. Sharma, excellent presentation. You had mentioned that better algorithms are needed to help predict risk early. Can you speak to the current status of existing algorithms, and then where do they fall short for the medical community?
Yeah, that's a really good question. So I think there was a recent paper by a collaborative writing group. Much of all of them were and this is focused on hypertensive disorder of pregnancy. Yeah, so I should clarify, it's not just all APOs, it's premature, is basically predominantly preeclampsia. So there was a writing group, and it was published in AJOG that looked at what can be done for patients that have a risk of an APO. And so obviously there is aspirin therapy, which is recommended 12 weeks onwards for patients that have at least one major risk factor for preeclampsia, such as previous history of preeclampsia or existing chronic hypertension, or you have lupus, or you're diabetic, or you have twin pregnancies or gestational, twin pregnancies, or also 2+, or at least 2 moderate risk factors being, maternal obesity and other issues. So having that insight for patients who may or may not have a prior history of preeclampsia, and making them at least get the aspirin, which is important. But then the other algorithms actually focused on identifying other risk factors that in a normal individual who wouldn't qualify for aspirin would still be there. So for example, you would have someone who has sleep apnea and has really bad sleep apnea, could be at risk of actually a premature preterm birth or a preeclamptic pregnancy. So integrating a screening for cardiovascular risk factors, along with screening for where preeclampsia can be sort of prevented with from aspirin use, is helpful. They also provided a nice way to address and assess for social determinants of health. Where are you going to deliver? What is your access of care? How is your neighborhood environment? What is your level of education? Where do you seek care? What kind of postpartum health you have or help you have? Those are important ways to sort of screen during pregnancy, so that if there are complications during pregnancy, we're not scrambling for it in the postpartum time frame. And also screening for blood sugar earlier in patients that you think are likely going to be gestational diabetic. These are the pre-diabetics, the ones with the pre-hemoglobin A1C, which is already not normal to begin with. So those are certain existing care pathways or care plans, and I would definitely recommend looking that up. Where do we fall short in the medical community? We focus on just one problem. I think that where cardiologists fail is that when we see patients of reproductive age, we do not take a reproductive history. We don't. We're not trained to do it. We don't ask about preterm birth. We don't ask about preeclampsia. We don't ask about lactation problems. We don't ask about breastfeeding. We don't ask about IVF, infertility. We don't typically think these sex-specific problems can cause their heart disease, can be associated with heart disease. So we need to do a better job at screening patients so that we understand their individual risks. And as OBs, we need to do a better job at understanding their cardiovascular health.
All very excellent. And thank you for that question. I was making several notes because I think these are opportunities to link some of this information on the VNPC website, especially because this parallels that Project Embrace screening and what is basic standards of care. So thank you very much for that question and that response. Any other questions that anybody has? All right, not seeing any, and there was time during that discussion to type. So I want to say thank you very much, Dr. Sharma, for presenting today. In the meantime, if anybody does come up with questions, please reach out to me. I will put my email in the chat, and I will make sure to reach out to Dr. Sharma if there are additional questions. But again, thank you very much for being here, and we are excited to see everybody in October. And have a wonderful September. Thank you.
Thank you very much.